please. Are you ready? One,
I'm ready.
2, 3, go!
I have to share my
Your screen, please. Yes.
your screen. How do I do?
It's a green button in the lower part.
Okay. I go?
Yes, go for it.
Okay. Okay. It doesn't work. I have problem to go with.
No
Zoom.
problem.
Okay.
Nati, Alfredo.
Okay.
Alfredo.
No.
Emilio, need to share the screen. No worries. Are you clicking down where it says share screen? Here we go. Okay, you got it.
Got it?
Yeah. Now just play.
Okay. So to change, let's talk about occlusion. In this webinar, I will focus on mastication, how you can integrate the analysis of mastication in the clinical process. I will give you some keys to be able to read Loré and Legald map of mastication. This is the goal. Sure, you will use your eyes differently, I think. I have to advertise that if you are a fervent user of canal guidance, just keep calm and enjoy. Okay? So briefly, where mastication takes place. Mastication is a good way to enter in the education process, as we talk about during the interview with you, Javier, with Amit. But beware not to disconnect mastication in a global view or holistic view, whatever the word you use. In my clinical process, I examine and check step by step fuse, behavior, then balance, and after load repetition where mastication will take place. So first step is to check the fuse. There's why patients are coming to our office when they feel worry about it. And what does it make sense to compare with a fuse? Because when the fuse is blown, two attitudes are possible. First one is to replace the fuse and turn back the power and pray for your fuse doesn't blow again. Just think in this first attitude on your own experience, thinking in tooth getting a crack, so a compo, and then after a necrosis, so an endo, and a crown or an onlay, and then a root crack, and so an implant, and finally a perio-implantitis, and a graft, and so on and so on. Second option is to try to guess why the fuse is jumping and figure out what's causing so much trouble. So depending on your advancement in occlusal knowledge, you will find clues to oriented towards an occlusal diagnosis. What is difficult is to recognize an occlusion situation facing simple routine because we work in areas such as tooth crack, periodontitis, ortho-migration, perio-implantitis, and endohealing problems, and this kind of problems. The advice is to step back and try to find other clues such as muscle pains, TMG issues, growing process disturb, postural issues, headaches, compression in cervical spine, constricted airway, and wound dentistry, and wound dentition, and so on. The thing is your fuse belong to an occlusal chain? That's the point. Second technique is behavior, nail biting, clenching, etc. The problem is the patient is not very aware on what they do with their jaw. So many things to say, but it's not the topic today. What we can say is how to drive the interview for the patient, how to collect the data, not to pass as a mentally ill dentist, because it's very surprising when dentists talk about those points. Which advice to give? The goal is to make patients aware that stopping clenching as much as they can will protect more their fuse, not to get worse. And it will be helpful for the patient and for your practice too. Next point to examine is to work on a balanced jaw. No doubt that today with all those fantastic speakers that you will see, we'll find some tips and tricks to know how to catch a good jaw position. I am used to play with different devices and adapt the tool depending on the situation. But the biggest issue for us is because it is so obvious, we focus on what is evident. So this MIP look well stable, it looks like. First step in the occlusal approach is to ask by yourself if you can or if you cannot trust this MIP. So go for a step back. And just to explain, because it's a crucial problem that often the dentist doesn't understand, that if you look at this wheelbarrow standing in the garden, if you really pay attention and you analyze the environment around, you will figure out that maybe this wheelbarrow is not so standing, but overturned in the garden. So after deprogrammation, if you ask your patient to close his mouth, you will discover if your MIP is overturned or not. And look at this case, contact in a position which is not MIP, and then the jaw is skidding to reach MIP. So when you are looking at MIP, you are looking at a position which is overturned for sure. So maybe the fuse you examine is suffering from this jaw deviation, and the question is, do I have to conserve MIP or do I have to go for a new position of the jaw? Okay, so here we are. Fuse blown, is it connected to with occlusion? And then we have to be sure that the patient behavior won't throw a spanner in the works, damaging even more the fuse. Third point is to ask by yourself, is your MIP you are facing can be trusted? Is another position has to be tested or stabilized prior to treatment? This is where you can check for the occlusal plan and what else, but it's not the topic of the day. And then last question is, when the jaw position is confirmed, is how to distribute the pressure in order to protect the fuse. So this is the point where it begins. To be able to play with load distribution and to really fuse whatever they are, you have to learn a little bit more about mastication. So let's focus on, I will show you how this dance together. Even if Francesca is a really good dancer, she didn't take the comparison, but she compared to a washing machine, which is a clever idea, but so on is Francesca, no. The concept of mastication is a result of the work of two men who were very clever too, Marcel Legas and Jean-François Lauré. It's a concept which is based on observation of patients chewing, really chewing food in the real life. They spend their time taking picture and movie from the patient, and they abandoned asking patient to show their lateral movement. So how do they describe mastication cycle? Two phases. First one is a preparatory phase, remote from the teeth, no contact in between the teeth, which is beginning at the end of the previous cycle. Two events in this phase. One is openure, and the one after is the closure of the jaw. And second phase, which is a dental phase, is with contacts. We have three events. One is cycling, which is called entrance to, and to be able the jaw to reach MIP. And second phase is cycle out, which is called also exit. And MIP, in the point of view, is the apex of the cycle pattern in the frontal view. So let's focus on contacts during cycling phase. We are analyzing what's going on the masticatory side. So here on the right side of the patient, very simple. Masticatory side on the opposite side, it's known as a non-masticatory side. So forget about walking side, balancing side, or whatever name you know. And do not forget that if patients switch the food, because they will switch the food when they are eating on the other side, because mastication is unilateral but alternate. So the non-masticatory side will become at a time will become a masticatory side and vice versa. So let's see again what happened during this phase of cycle in movement. And clinically, what I'm drawing you here is pattern of the summit of buccal lower cusp, getting contact on upper buccal cusp on right to reach MIP. Is it clear for you? Okay. Meanwhile, on the lingual side, the internal part of lower cusp are driven by upper palatal cusp on their lingual side by a point called entrance superpoint. Okay? So little details now about the key of mastication. I named the couple of first molar, which is a very important couple of teeth. In a static point of view, you can observe that the upper molar is the distal cusp of the first upper molar is diving above the first lower molar. And one thing that Marcel and Jean-François noticed is the railway that you can find between second and third buccal cusp on the lower first molar. You know, the ones that oftenly lab technicians don't know what to do with and forget to include in our restoration. And putting them together, the lower V-shaped channel on the upper enamel bridge, it leads to an harmonious mastication movement. This is the principal point to check, the most important point that will help you to obtain a very kind cycle. And once teeth reach MIP, to leave out from this position, here is the second phase starting. It's cycle out or exit. So let's have a look again on the motion because you have to integrate this notion. So here you have cycle in, reaching MIP, and then cycle out, okay? I show it again to be clear. Cycle in, MIP, cycle out. We are speaking about the masticatory side, okay? At this time, lower buccal cusp are able to crush food against upper palatal cusp. And here it's the phase, in this phase, occlusal slopes, if you look at very closely, you will find that the slopes are very flat and wide. And the reason is certainly because they need to resist to the grid strength applied during this phase, this exit phase, which is you have to connect with anatomy on to guess why Carabelli tubercula exists. I think, and no doubt, it's a kind of mechanical resistance beam to resist to this extraordinary forces. And what is particular in this phase is the jaw needs to be driven by the proprioception of the opposite canine, so well innervated to guide the movement. You can see on the left side, which is mastication side, you can see there is an inflection in the movement after MIP. The entrance is more lateral movement, and after reaching MIP, there is a change in the direction. That's why we need the canine on the opposite side to guide the movement. It looks like a kind of lateral movement on the non-masticatory side, but it's not really the same, because in the same time you have contact on the masticatory side. So I will explain why in a while. To resume, cycle out, the difference is, sorry, I missed something. Okay. So to resume, here we are looking for cycle out map. On masticatory side, you can read slopes of exit. And sorry, I go too fast. And on the non-masticatory side, you can read a guidance of the canine. On premolar, you have to ask yourself, is a patient, because the patient have shoe on the two sides, is it on exit slopes or entrance slopes? So you have to ask patient to shoe again and to check if you have a congruence between the teeth during exit or entrance to know if it belongs to entrance or exit. So what makes difference between mastication concepts and lateral occlusion concept of lateral guidance, canine guidance developed by D'Amico? If I show you those animals to study mastication, what would you do? I think you would probably record them when they are eating and trying to analyze. What do we pay attention in our office is just to study our occlusion patient, no mastication concern for sure. What we hope is we will find a very nice canine guidance with a fantastic posterior desocclusion. That's the goal in dentistry actually. But there is a big difference between mastication and lateral occlusion. The difference is in physiologic of muscles. Here's the point. Cycle in recruits levator muscles, and that's allow contact in entrance guidance. Whereas lateral movement recruits the lower lateral pterygoid on the opposite side, which is a depressor on lateralizer muscle. So not the same muscles are involved. That explains why you can have such difference in teeth contact. opposite action direction muscles leads to effects which are quite different, logic. And same analysis for cycle out and lateral movement. In cycle out, you will get contact on the mastocytory side because you are recruiting levator muscles, whereas in lateral movement, you will recruit the opposite lateral pterygoid muscles. So that's why you can observe the absence of posterior contacts, asking people to have a lateral movement. On this same patient, you can find some occlusal posterior wear, which are not logical with lateral movement. But these occlusal wear are not parafunctional, definitely not, because if you ask people to cycle, to masticate, you will find congruence between these teeth during mastication. So they are not parafunctional wear, but functional wear we don't explore, asking patients to show lateral movement, which is a lateral non-functional movement, instead of functional movement of mastication. So now, how to explore mastication? Basically with the gum. Hollywood Max is really great because very easy to hydrate, very easy to crush for a patient. And you have to connect this movement to occlusal marks, which will reveal the Loré and Le Gall map of mastication. But be sure that the patient is not only biting the paper, you have to be sure that he is masticating paper in order to get this map of mastication. So that's what you can see on the state of the paper, which is masticated here, okay? Now have a look on anterior teeth. Thinking in anterior teeth, we often think in protrusion movement and anterior guidance. Forget it for a few moments and remember that the anterior teeth are involved in mastication too. So lower incisiva are traveling behind upper incisiva in this posterior view. And if you connect mastication knowledge to Plana's heritage, it will give you a lot of key to understand periodontitis or automigration, for example, concerning anterior teeth. So here, same story. Muscles involved are different, so protrusion and incision can be the same. Okay. Protrusions means for a lot of us Christensen's phenomenon. So posterior desocclusion, right? And on incision movement, you will observe posterior contacts. And on anterior teeth, you won't obtain neither same contacts, neither same strain compared to protrusion. According to what I explained, does it make sense now why patients come after successfully equilibration done regarding to dogma? Why do they come to office? Why do they come back complaining about discomfort? Because we didn't explore all the physiological movement. So now let's go for a few clinical consequences. First one is knowing Loré on Le Gall map of mastication, you will be able to restore, to build up marks to make patient able to chew. And what is impressive is no adaptation is needed. If you achieve a good shape, patient will be able to chew directly. Beware not to lose or disturb jaw position or not to lose slopes that are already functional. The goal of this adjustment is to obtain a good envelope for chewing patterns. all cycle patterns depending on food you will eat are included in this envelope limit. Reinforcing missing slopes will influence the density of condyle. You see on the right side of the screen, the entrance guidance is missing. Proprioception doesn't work. Side shape will be impact to be more vertical, but it can also, if the patient is clenched, impact the condyle dens and compress the anterior part, the posterior part of temporomandibular joint, or it can be the disc which can go in mesial place. You can decline it for support of entrance is missing on the right side. The condyle will dance in the other way and will lead to other issue. So you have to decline all these consequences to each phase of mastication, thinking in overguidance or infraguidance, which make a lot of situation, and connect all this observation with the fuse that has blown. So knowing lower and legal map of mastication, you will be able to connect mastication and symptoms. Here, I guess you can see that entrance guidance is missing on first and second molar on the right side of the patient. On second premolar entrance guidance is not so fantastic. Support point looks good and exit looks good. Many lab consequences to tell just one is, in order to chew in a sagittal view, condyle on the masticatory side needs to go a little bit backward before going forward to reach MIP. So that's why condyle can be so retreated in MIP, and information that will be please Javier, I think. On physical articulators, the problem is often we can't do this movement because the posterior wall of the condylar box can't make the movement happen. The question is why on virtual articulators the patient is not the reference. It should be because physical articulators have been copied to program digital articulators. That's a question. And a point which is very interesting in, according to a study of Marcel Le Gall and his son Nicolas Le Gall, occlusal shame has a huge impact on peri-implant bone level. Improving mastication, showing patterns, they managed to gain 1.3 millimeters average of highness bone around implants. So clinically, when I face a U-shaped bone defect, I check occlusion and mastication first. Last question for skeptics of you. How did you chew while you were 6 old to your 12 years old without any canine? This is the question. Here you can figure out the importance of the first molar into the well setting of the denture. And you can figure consequences if your auto treatment rotates molar to expand the palate, which is a good idea. But you are rotating the molar, you are removing the proprioception key of mastication. So you are removing the key of stimulation, and so the key of the growing process. You can figure out the importance of the phase before 6 years old to make happen a good efficiency of first molar couple. This is a very crucial point. You can find many other information on the website of Marcel Le Gall, which is masticationppp.net, in English and French, many publications. I hope you enjoy. If you want to know more, to go deeper, or take time to integrate this concept in your practice, come and visit our superb island in Indian Ocean, or tell me I love traveling.
Yes, oh my God, you were totally right. My head is gonna explode. If you see me when you were lecturing, I was checking myself. And now I was seeing, now I don't even know if I'm gonna show you the video of the two cases that I gonna present tonight. My God, honestly, this is fascinating. A lot to learn. I guess the
Beautiful
people
work.
also, yes. Oh my God, so much, so much to think.
So much to
Now I
learn.
think that yes, exactly. No, but much is also too much to be able to see because it's a challenge to see inside. So that's why this technology that is coming about your trackers with optical cameras and all that is gonna become really handy because honestly, I think it's really difficult. You made beautiful points. Honestly, God is amazing. This is the conclusion. How
You know
perfect He
what?
is.
You know what I think. There is some connection between uh, what they're doing and what Dr. Kirstein was talking about, the neurophysiology of the teeth. There is something that they are correcting in this functional movement checking and this masticatory correction that must settle the whole nervous system. So there's so much interconnectivity between our speakers. I mean,
so much thing to add because
yes.
it's a little part of the.
Oh, I'm sure. Half an hour is barely enough to scratch the surface, right?
Yeah.
Oh
Yeah.
my God. No, but really
It
fascinated.
opens a lot of perspectives, so it's really amazing.
No, the last two things that you say, like how I was thinking the first molar, honestly, was just to hold vertical dimension, but now it makes sense. It hammers and helps to form the fossa, and also the caravelli tubercle is so important. It's not an aesthetic feature for sure. It's reinforcing the hammer because that's the matching. And that things make sense, you know. So this is honestly really, really fascinating. Again, we recommend the people honestly to go. Dr. Legal has all these publications for free in the website. His interest is people has access to this. Believe me that he's a really important person and he's giving us a great legacy. We hope, and we know that he's having some medical issues. Emilio, we don't gonna go deep, but we have. I never have the opportunity to meet him, but always my dream was to be able to meet him. And Emilio was trying to
For
create
French
a
people,
bridge.
there is a formation in Strasbourg with University of Strasbourg with Roger Jorger, and Roger Jorger is a speaker too. He's a German. He can speak German. For German people, it's interesting.
Yeah, that's awesome. And definitely, as we've been talking for since we met, definitely we're gonna bring you here, and then you definitely need to share with us because this is a fascinating war, and it's worth it to go deeper. As a fact, you went really good with time.
I know.
Yeah.
This is the you know, I had heard about the Swiss exactness, but now we're seeing another side of the French.
Tropical time.
Thank you so much, Miliau.
Thank you.
As always, this has been pleasure.
Emilio, thank you so much. We're having a technical issue with the next speaker. Let's see what's going on. So we can technically keep Emilio in the line. Mitch, can you check if there's any questions?
I know Lawrence already got the email. He should be connecting shortly. But
yeah. Camille, can you check social media? Because Natalia is using my phone now, so I can check if it's any question for the audience, please.
Yeah.
Okay, I get another phone over here. Okay.
Excellent presentation.
Okay, we don't have questions.
No,
all right, we're good to go, I think.
Okay, we got it.
Got it. Bye-bye.
I bet, Emilio, we love you. Thank you so much for everything. We have another winner! Winner number 2!